Hello, and welcome to a Health Podyssey.
It was kind of surprising just to see the range of providers that actually said, look, that this is a good deal for us and this is something that we want to participate in.
I'm your host, Alan Weil. Episode-based payments, also sometimes referred to as bundled payments, are an innovative payment model designed to overcome some of the shortcomings of fee-for-service. In a bundle, you get a single payment for an episode of care with a defined beginning, a defined end, and inclusion of all related services. Bundled payments have multiple goals. They're designed to increase accountability and coordination. And of course, they're also designed to create incentives for efficiency and saving money. Now, the Medicare program's been a leader in using bundled payments, and much of what we know about their effectiveness comes from Medicare. We know less about potential savings associated with episode-based payments among private payers. That's going to be our topic today. On today's Health Podyssey, I'm joined by Dr. Chris Whaley, a policy researcher in healthcare at the RAND Corporation. Whaley and co-authors evaluated a payment program developed by Carum Health and used by self-insured employers. We published the results in Health Affairs in March of 2021, and they're really quite dramatic. That's what we'll be discussing today. Dr. Whaley, welcome to the program.
Thank you, Alan, and really excited to be here and to talk about our paper.
Yeah, let's talk about your paper. It's got some really interesting findings, but let's make sure everyone understands what it is you focused on in your analysis. So I gave the one-sentence version, but say a little bit more about the concept of an episode-based payment or a bundled payment.
Sure. So one of the things we know about the U.S. healthcare system is that there's lots of variation in both price and quality. And a lot of the variation in spending and quality is due to things like readmissions, complications that maybe could have been avoided. And so Medicare has really been at the forefront of addressing this variation by using bundled payments. And so what this does is it gives the provider a set window of period where all the costs are covered by a single fee. And so if you're an efficient provider and you're able to cover everything within that period at a lower cost or operate a bit more efficiently, then that's a way for you as a provider to make money. And if you're a provider that maybe isn't able to operate as efficiently, then this is a pretty strong financial incentive for you to be a more efficient provider.
And efficiency here can presumably come in a lot of different forms, right? What does it mean to be efficient as part of a bundle?
Exactly. So really what this is about is managing patient downstream services. And so one of the big areas of cost drivers and spending drivers for things like surgeries, and especially things like joint replacement surgeries, which are kind of big ticket items, is things like readmissions. So some patients, the initial surgery might not go well, and they have to come back in and get a revision, or a patient may not have a great outcome during the surgery, and so needs to be discharged to a high cost center. And so if you hold the provider account for everything that happens in a longer window than just the surgery itself and just the period of performance of the surgery, then that gives the provider an incentive to be a little bit more holistic in how they treat the patient.
And I could see efficiency occurring, as you say. A redo is obviously very expensive, but it's also about the price, right? If you send someone off to a rehab center that's very expensive, and that's part of you're basically paying for it out of your own bundle, you're going to have an incentive to find a cheaper one. So that's like efficiency is both quality and sort of price cost. Is that right?
That's right. And so those types of factors all exist in the Medicare system. But on the private side, the variation in price and in cost is actually quite a bit larger than what we see on the Medicare side. And so in the Medicare bundled payment model, there is a pretty strong financial incentive to be more efficient. And there are several studies that have actually shown that providers really do change their behavior under the Medicare program. And so what we're interested in is in a setting like the commercial market where you have the same utilization variation, same quality variation, but just an order of magnitude larger price variation, how do bundle payments work? And so that's what we wanted to do in this study.
Okay, so let's tiptoe our way up to the results because you've put a lot out there on the table. Let's start with the service type. Not everything can be bundled. Not everyone tries to bundle everything. Where do we see most of the activity around those who are trying to use bundled payments?
Yeah, so these are mainly big ticket surgical services or big ticket items where the service is expensive and there are associated downstream costs. So whether that's sending the patient to a different type of rehab facility or potential revisions or readmissions for the initial surgery. And so in our study, we looked at 3 surgeries, so spinal fusion surgeries, major joint replacement, so this is mainly knee and hip replacement surgeries, and bariatric surgery.
And these are common places to look because, as you say, they're big ticket, they're relatively frequent, and they have a kind of defined beginning, middle, and end.
That's right. And another thing I'd add too is that these are, in some sense, shoppable services. And so if you need a knee replacement, you as a patient have some leeway and some time to decide, I want to go to this provider or that provider. And so if you're thinking of something like, say, an emergency room visit or something like that, there's really just not the same level of ability for patients to decide where they go. And so a bundle wouldn't really be appropriate for those types of services.
That makes a ton of sense. So you teed up some of the differences between Medicare and commercial, but let's start with what we know from Medicare. So what have we learned? What are the key lessons out of episode-based payment on the Medicare side as it relates to these major surgical procedures?
So I think the main savings are twofold. So one, providers seems like responded to these incentives by being more efficient and providing better quality of care to patients. And so things like readmission rates and discharges to high cost sites of care actually decreased. And then as a result of this, Medicare spending went down by a couple percent for these services. And so overall, I think the results have been pretty encouraging for the Medicare bundled payments.
Yeah, so that's a great platform. I mean, we're all looking for ways to save money. And so here's a nice starting point. But now this program you studied was in the commercial market. So tell us a little bit about what they did.
That's right. And so this program is for the employer-sponsored market, so people who get insurance through an employer. And overall, the system is relatively similar to the Medicare model or built, I think, on a lot of that same logic. I think there is a key difference here in that in Medicare, prices are pretty much set across the board. And so the price that one hospital or surgical center charges versus another is more or less the same. So a lot of the Medicare savings come from all these downstream costs. On the other hand, in the private market, the price that one hospital might be charging might be, 3 or 4 times the price that another hospital might be charging. And so there's just a tremendous amount of variation in price. And so to address this, what this program that we study does is actually tie the bundled payments mechanism to a preferential negotiated price. And so what this model has done is said to individual providers, look, we're going to give you a lower price and a price that is included in the bundle or paid through a bundled payment. And we're going to send patients through this bundle to you. And so you might think that if you go to a provider and say, we're going to pay you less than maybe you would otherwise, and we're also going to tie this financial incentive to that payment, that most providers would just say no. But it was kind of surprising just to see the range of providers that actually said, look, that this is a good deal for us, and this is something that we want to participate in. And I think the reasons are really twofold. So one, if you're a provider that participates in this bundled payment program, then you know that you're going to get kind of a steady stream of patients. And so maybe it's at a lower price, but you're getting those number of patients in on a pretty constant basis. And then the other, I think, strong reason for providers to participate is just the way that the payment's actually made. And so the payment is part of this bundle, but it's a check that kind of comes in all at once. And so if you're a normal, or if you're a provider operating under a normal environment, each service that's done has to have a bill, and you have to work with your billing department and go through the insurance system. And there's just a lot of administrative hassle to actually get what may be a higher price. And so here, maybe the overall amount is lower, but you as a provider get that in on a kind of a guaranteed basis and know exactly what you're getting. And so that's just, I think, a little bit easier administratively for many providers to deal with.
Let me just ask, I mean, we talked about Medicare leadership in this area. Presumably the same providers who are doing knee replacements for the commercially insured population in this program are also doing knee replacements for Medicare enrollees who may be in one of these payment bundle models already. So presumably this wasn't like a total shock to the system for these providers. They were familiar with the concepts and maybe even had some experience in the program?
I think that's a really good point. We didn't test that specifically in the paper, but as Medicare over the last couple of years has really popularized and gotten providers to accept these bundles and kind of learn how things work, if you will, then I think that just generally makes it easier for these types of payment models to work for the commercial side.
All right. Well, we're going to hear the results, but I think maybe we'll just tease everyone with a quick break. And when we come back, we'll find out a little bit more about what the results of this experiment were.
Enjoying the show? Make sure to subscribe to Health Affairs Today to catch a daily roundup of news, analysis, and commentary. Topics range from federal and state health policies to the latest on health inequities. And it's free. Head to www.healthaffairs.org and click Newsletter Sign Up in the menu to join the premier health policy community.
And we're back. I'm talking to Dr. Chris Whaley about a study he led that shows the results of an employer-provided bundled payment program, particularly focused on major surgeries. Before the break, you laid out what the program looked like. So what'd you find? Let's start with sort of the basic findings. What happens when you impose this alternative payment model on a commercial population?
Overall, we found that the program worked as I think we expected it to. And so for the employers that implemented the program, their overall costs fell by about 11%. And so this includes people who went through the program and those who didn't. And about 20% or 20% of the people actually went through this program. And so the people who actually went through the bundled payments program saved about $16,000, or rather their surgical procedures were about $16,000 less expensive than those who didn't.
I have to stop right away and say those are, we publish a lot of studies where the results are 1% or 2% here. Those numbers sound really big. Can you put them in the context of what we know about the Medicare bundled payment programs?
Yeah, so the Medicare bundled payment program across the board saves about 3-ish%. And so just due to the wide variation in prices, the savings that we're able to get on the commercial side are about 4 to 5 times larger than what we have on the Medicare side.
Okay, I just had to stop you there because I don't want people to miss that. So, and this is presumably in large part because you have a price lever here that doesn't exist in the same way in the Medicare side, in addition to all of the other coordination and accountability changes that may occur within the Medicare program. Now, we don't get deep into methods in the podcast, but one thing that I did think was important is you present sort of the mean savings, which you just described, but you also present the distribution of prices. And I just wonder if you can explain why it's important to look at both of those when you're trying to understand the effects of a program like this.
Yeah, so one of the things that we highlight in the article is just the wide range in prices that we see on the commercial side. So, for example, if we look at spinal fusion surgeries, we find that the people who didn't go through the program, the difference between the 25th and the 75th price percentile is almost $100,000. And so that means that some patients who, for whatever reason, go to higher price providers are accounting for $100,000 or nearly $100,000 in costs relative to patients who went to lower price providers. And if we look at providers or patients rather who went through the bundle payments program, There's essentially no price variation. So the difference between the 75th and the 25th price percentile for bundled payments, or for patients who went through the bundled payments program, is about $2,000. And so the overall distribution of price is quite a bit narrower in the program.
So you're not just shifting the cost curve down, you're dramatically squeezing the variation, which is something, people have been studying and trying to figure out how to tackle for decades.
That's exactly right.
Say a little more about what you know about the types of patients, types of services, and maybe as a part of that, we talked about the difference between Medicare and commercial having to do with the pricing, but there's also a difference with respect to patient cost sharing because you have flexibility in the employer program. So maybe if you could pull those two themes together.
Yeah. So one of the ways that this program was actually get patients to go to lower price providers is to say, look, we're not just giving financial incentives to providers, but we're also going to give a financial incentive to the patient. And so if you're a patient who chooses to get your knee replacement or your bariatric surgery or your spinal fusion surgery at one of the providers that participates in the program, then this program actually waives all cost sharing for the patient. And so that can be a pretty big incentive for the patient. So the providers that are part of the list are, I think, pretty high reputation and high profile providers. So for example, the Mayo Clinic, Johns Hopkins, Stanford. And so if you can go to one of these kind of name brand facilities for free, then I think most patients would say that's a pretty good deal. And so,
we talk a lot in healthcare, particularly people who are focused on the cost side, about alignment of incentives between providers and patients, and about how the structure of insurance, with a deductible, once I've met my deductible, I have no reason to pick a provider whose pricing is lower, who's going to get paid a little less because it's all borne by insurance. So this is one of these relatively rare places where you can say to both the provider and the patient, you'll both be better off if you make this decision. And that alignment seems like that's a major factor in this design.
That's right. One of the things that I really liked about this program and our results is that in some sense, three parties win. So one, the providers win from both getting more patients and having a lot more simplicity on their administrative side. Employers win because they save $16,000 per patient who goes through this program. And then patients also save quite a bit. So we found that due to waiving cost sharing, the average patient cost sharing per patient actually fell by about 28%. And so if you look at the patients who actually went through the program, they save around $2,000. And just to put that in context, that's the rough average high deductible plan right now. And so essentially you're just through aligning these incentives a bit more intelligently, essentially getting rid of a high deductible plan for these patients.
Employers, particularly large employers who under federal ERISA are exempt from state insurance regulation, they are very protective of the flexibility they have by not being subject to state regulation. You've just described a scenario. You said all three parties win, employers certainly win, but you also just told me that Medicare has been the leader here. Why aren't employers, if they have this flexibility, running full speed ahead toward this model?
So that's overall, I think, a good question. I do think that there has been lots of interest in this model. And so we looked at this model. I think our data cut off in early 2020, but I think over the last couple of months, they've really expanded both the number of providers that participate in the model. And so people in more markets now have access. And then also the types of products or the types of services that work through this bundle. So for example, oncology care. And I think one of the reasons that maybe overall these things have been a little bit slow to take off is just what's the effect hasn't really been known. And so hopefully as people understand that, look, these are types of models that can both benefit providers, employers, and patients, that maybe there might be more growth.
Yeah, so it's always a little unfair to say it's not happening, and we of course hope that with publication of evidence like this, it helps people make better decisions. Critics of bundles talk about two items. One is this is all about price per unit, but it doesn't affect units. So there's no if the cheapest knee replacement is the one that doesn't happen, and this doesn't generate any savings around that. And then you sort of on the flip side have the concern about patient dumping or screening out. Wow, that's a really complex knee, or you've got some complex conditions. I'm only going to get paid a fixed amount for this. I don't want to take you as a patient. And that can be quite informal because you don't typically want to leave a paper trail behind that, but it can have some real negative implications for the most complex populations. So given your overall understanding, I don't just mean from this study, do you feel like these critiques are valid?
Yeah, so I think they are important to keep in mind. And so the program that we study also has, before the patient even gets to the bundle, an initial screening. And so this is a way for the provider and the patient to decide if a surgery is actually even necessary. And so one of the nice features of this model is that providers who give that initial screening to the patient and then decide that the patient, or jointly decide that maybe the patient doesn't need the surgery or maybe can wait to get the surgery, actually receive an additional payment. And so this is an additional provider incentive to maybe use resources a little bit more intelligently. And then for the broader concern of kind of, does this potentially lead to cherry picking healthiest patients and maybe avoiding sicker patients? I think that's a real issue. And so I think it's important to risk adjust these payments and make sure that we're actually giving providers incentives to still treat higher risk patients.
Well, let me close you out with a sort of forward-looking question with respect to program design and research. We've learned a lot, but there's always more to be studied. We're in a new presidential administration where we've had a new named director of the Centers for Medicare and Medicaid Innovation, which is where these bundled payment experiments have taken place. If you were to design the next bundle model to learn what you think is the most important question to be learned about episode-based payments or bundles, what would some of the features of that next model look like?
So I think the big question is this is right now I think a kind of boutique program, and so if we're to expand these programs much more broadly and in some sense make this the new norm, would that actually lead to broader changes? Just as to kind of highlight where maybe those impacts might come. In our study, we find that overall costs fall pretty considerably, but the employer in some sense gets a kind of 8-to-1 ROI on that declining costs. And so if we're to expand this to a broader set of services, does that ROI and that investment change? And then I think the other interesting question is, and this kind of actually gets to one of your earlier points, if you're a provider and now have this incentive, whether it's through treating your own patient or through the Medicare system or through commercial payments like programs like this, does that actually just change how you as a provider practice medicine? And so even patients that you see who don't necessarily go through this program, do you maybe learn lessons from the bundled payments program and actually improve care for those patients? And so if that's the case, then there could be broader societal spillovers and just a kind of general increase in both the quality of care and efficiency savings.
Well, we'll have to make sure that the right people listen to this podcast to get those ideas, because it really is striking both what you found, but also, as you note, because so much of this is tied to both pricing issues that don't apply in Medicare and to incentive alignment with patients that's much harder to do on the Medicare side. We still have a long way to go to figure out what we can do in this area. Really appreciate you spending the time with me to talk about this. I consider this to be very important and interesting research, and so glad we were able to publish it, and look forward to seeing what you do next on this and other topics. Dr. Whaley, thanks for joining me on A Health Podyssey.
Thank you. It's been great to be here.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.
Health Podyssey is produced by Health Affairs, the leading journal for health policy research. The team behind the show includes Patty Sweet, Jeff Byers, Julia Vivolo, Sarah Kolk, and Sue Ducat. Like the show? Subscribe to a Health Podyssey on Apple Podcast, Spotify, Stitcher, Google, or wherever you listen to your favorite podcasts. Thanks for listening, and have a great morning, day, or evening.